All right. Thank you, everyone, for joining us today. Today's webinar is about physician leadership in the era of value-based care. I'm Lisa Towers, Director of Marketing for Lumina Health Partners. And we can go to the next slide. So here are some housekeeping rules as we move through our webinar today. The webinar will be about 30 minutes, and then we'll have 15 minutes of Q&A. So if you have any questions while you're listening to the webinar, please feel free to use the toolbar at the bottom of your screen. It looks like this black toolbar where you can use the Q&A function to ask questions and submit them to me. You can also use the chat function. All participants will be muted during the webinar, and our presentation will be emailed to all participants after the conclusion of the webinar. And our next webinar will be on January 16th at 11:30 a.m., Clinically Integrated Networks, Realizing Their Real Value. So we'll send a link in a follow-up email where you can register for that webinar and also take a survey to give feedback on this webinar. Next slide. So Lumina Health Partners is just a little bit of information about us. We're your partner on the journey to value. We have recognized industry leaders who work hand in hand with our clients to guide healthcare organizations as they optimize the performance of programs to meet the demands of an increasingly value-based care payment environment. Next slide. These are our services that we provide: value-based strategy, digital innovation and analytics, clinical transformation, and leadership and governance. And today our webinar topic falls under the leadership and governance category and the Luma Leadership Institute, which is one of our offerings that Dr. Faber will talk about today. Next slide. Today's presenter is Dr. Will Faber. He specializes in population health management, medical group management, physician engagement and leadership, quality improvement, and the optimization of health information technology. So I will hand it off to Dr. Faber. Thank you so much for joining us today.
Thanks, everybody. Hope you can hear me all right. And happy holidays. Thanks for spending a half hour to 45 minutes of your busy day with me. Why is this topic relevant? We're going to talk about that today. And I'm going to talk about what constitutes a great leader and what you do to develop and find and develop your physician leadership capabilities at your local institution. The topic is relevant because more and more healthcare is demanding physician leadership. Healthcare is expanding, and there are lots of new roles like Chief Medical Information Officer and Chief Quality Officer, and you've got doctors that chair committees. And more there's a need for the roles, but also there's a need to improve the skill set of those who are in the roles. And why are physicians being called for more and more to be in healthcare leadership? Because, well, first, healthcare is the largest private sector of the economy. It's a sixth of our economy. And it's a workforce of thousands and thousands of doctors who, for better or worse, are more influenced by a physician talking to them about business matters than business people that have no clinical background. I call this the influence advantage. Also today, we're going to be talking about value-based care, and I'm going to make an argument that the world is going toward more and more demand for value out of its healthcare services. And that's where you really need the brains of care providers, clinicians, and physicians to make some of the tough decisions you have to make about what is value added and what is not value added. So we definitely need physician leaders. Now, this is predicated a little bit on some new reimbursement realities. And I presume people who've signed up today have value-based payment systems in their neighborhood. There's hardly a place in the United States where the demand for value is not hitting us. And of course, we've included this picture of the man with a foot in two canoes, because in most markets, there's still a lot of fee-for-service activity, which actually rewards you for different things than the fee-for-value contracts. And of course, it changes from one market to another what the mix is between those two value streams. But what I would say in this slide is no matter what your mix is between fee-for-service and fee-for-value, the needle is definitely moving towards value. Medicare has really thrown down the gauntlet with macro legislation, and that's got bipartisan support. We don't see that going backward. 40 out of the 50 states now have managed Medicaid, I'm sorry, and many commercial payers across the country. Medicare Advantage plans and commercial HMOs are getting in the game. They're kind of following suit. And really, when you think about it, there's no other part of the economy where people are not looking for value. Who wants to pay more for a lousy product? And for years, unfortunately, healthcare kind of went off onto adding more and more services without always being critical about whether or not each one of those services was really cost cost effective. And one of the things that's really got the attention of the consumer nowadays is high deductible plans. When the first $6,000 comes out of your pocket, now we have a little bit more interest in our consumers as to what's really value added and what isn't. So since Lumina really focuses a lot on helping clients in their journey to providing more valuable services and doing well in their value-based contracts, my comments about physician leadership are specifically tailored to those environments. I've alluded to this progression across the bottom of the screen. Fee-for-service was the way most everything was until 20 years ago. And then there was pay for performance and other kinds of value-based purchasing and so on. Bundled payments are an example of payment for value. And eventually, we're going to get to a global capitation kind of situation where many of the large systems are now creating their own health plan, and they don't even have insurance companies as middlemen money and redistributing it and garnering the premiums. And as I said, if you're going to be cutting out waste and improving quality, which is absolutely necessary to do well in these contracts, you need the brain of a physician or a clinician who knows what's wasteful and what's cost effective, what really benefits the patient, and what has a lower marginal benefit to the patient. So I want to talk a little bit about attributes of great leaders, and I put a picture of Atul Gawande up here. I'm a personal fan of Atul, but what I want to point out about Atul is he doesn't have years and years of experience managing, being a businessman per se, and yet he's just gotten the nod recently to be the CEO of what could be a very powerful organization sponsored by Amazon, JP Morgan Chase, and Berkshire Hathaway. And why did he get the nod? Because he is a well-known thought leader. He has done some very bold pronouncements. He's said some things that have disrupted the way we think about healthcare. And interestingly, what Atul Gawande is all about is about value and cost effectiveness. But he got the position because of his values as stated in his many articles in the New Yorker and his books. He's got a master's degree in public health. He's a surgeon by training, and he's a very smart man, clearly. But the reason why he got this really influential position amongst all people in the United States or even the world is because of his thought leadership. And so I've listed things that apply to not only physician leaders, but any leader. Generals, presidents, people who run large corporations. They have to be people of courage and resilience. Things are not always going to be easy. They've got to have really superior interpersonal skills and be able to influence their colleagues. They obviously have to have a strategic perspective, and they need to have emotional intelligence, which we're going to talk a little bit more about, decision-making capacity, and be accountable. And they have to be able to work through others and develop teams. And they have to be creative, or else you can't be innovative. Well, not everybody has got these personal attributes. And so the first thing I would say about finding physician leaders is look for people with strong moral character. Look for people who've got these attributes of great leadership. And then you can train them for specific content and skills. And you're going to have to work with the best people that you can find that that have those characteristics that you really want in leadership. And I put this slide up because I've been in a number of leadership positions over the years, and I've had the privilege of mentoring other position leaders. And there are going to definitely be challenges to the character of the leader. And I've given two examples here. How do you approach a senior physician who's had a lot of large legal settlements for surgical complications? And what if they contribute to the hospital or healthcare system more than any other person on the medical staff in terms of cases? What I'm pointing out here, and I have lived through this on multiple occasions, is physicians even who've done wrong site surgeries, and not just one, more than one. And the leader has to effectively confront the situation, but there will be a lot of back pressure if that person is a big financial contributor. There's a conflict in healthcare sometimes between big money and what's profitable and what's the right and safe thing to do. That's one example. Here's another one. What do you do if somebody is reported of having alcohol on their breath? It's not proof that they're drunk or intoxicated, although the comment may be that they aren't acting right. But a physician leader is going to have to confront that person quickly. But what if he's your best friend who you like to go golfing with? It gets hard. You have to make some tough personal choices. Those are just examples of places where moral character and those attributes of leadership are what you're going to want to be looking for, because then you're going to go into teaching them various things they may need to know. Now, depending on the setting and depending on the specific leadership role, doctors need to have different technical expertise. Most doctors in leadership need to learn something about finance, at least be able to read the financial reports of the institution. But there are lots of things about managing physicians, like the principles of peer review, or how to do quality improvement, or how to prepare for the Joint Commission, or how to work with the board of the organization. You need to understand these payment models and all their nuances. You have to sometimes, depending on the role, be a recruiter and work a lot with contracts and determine the fair market value of doctors. You can see from this long list, and of course you're going to get the slides at the end of the presentation, this is just a sampling of the many kinds of specific things doctors may need to learn for their leadership roles. And the point I want to make about this is there's different ways to provide the training. Some doctors go off and get a medical management degree or an MBA. Other doctors get kind of trained on the job. And there are ways in which you can use seminars or a longitudinal Leadership Development Institute to tailor make the skills training to the specific needs of that physician leader. But I really want to point out this part as well. IQ and those technical learned content areas that I just covered are important, but so equally important is EQ, your emotional intelligence, which has been emphasized a lot in the last 20 years. And it's absolutely critical to effective leadership of any kind, and particularly physician leadership. And the point I want to make about this slide is those are learnable skills as well. Some people innately have a higher EQ, but even people with a relatively low EQ or a relatively high EQ can do better. And this is talking about things like crucial conversations. Here we entitled it Critical Conversations. How do you confront people appropriately and effectively? How do you give them feedback so they don't just resist? How do you deal with conflict? And there is inevitably conflict in many of these situations. How do you teach leaders how to take care of themselves so they don't burn out, so they have some resilience with all the trials and tribulations they may go through? And how do you run meetings and projects effectively? Very important skill. I'm going to touch on this running meetings effectively in a moment. Um, Physician leaders, by nature, by definition, have to engage other physicians. That's why we need physicians in leadership to bring along this large and important workforce of doctors and align them with the needs of the institution to ultimately satisfy the demands of the consumer, and the consumer's demands are expressed through their insurance product or whoever's paying for health care. Well, one of the things physician leaders can do is share power, uh, chair committees, and get other physicians in a situation where they can sit around the room and come up with meaningful conclusions that would not be reached if the physicians did not get together. In other words, it does no good to bring everybody into a room and they really wrestle with a subject and then their conclusion is disregarded because somebody in administration already determined how the outcome has to be or needed to be. And this is scary for organizations to give up some level of autonomy. But what we've encountered in all kinds of clinically integrated networks, ACOs, and other organizations that require physician governance is that you put some parameters or guidelines around the limits to which physicians can make the decision. And they're pretty well recognized guidelines. The board may retain some reserve powers about total monetary spend or whether you can sell a big asset or something like that. But when it comes to things like selecting quality metrics, it's very important to give the physicians real decision-making power. Well, to do that, then you've got to get the physicians to come to the committee, and this is often a struggle for organizations, for people in positions like those of you who are listening to this webinar. How do you get doctors to come to the meeting and make those kinds of decisions I just alluded to? And I really can't emphasize enough that those meetings cannot be viewed as a waste of the physician's time. So the physician leader needs to learn some skills about how to collect the right people around that table. I recommend that there be some variance of thought process, maybe some employed physicians and some independent ones, some primary care doctors and some specialists, someone from the urban center or the large medical center, some from the rural or satellite center. That's the kind of balanced board or committee that you want to have. But then you've got to come up with a meaningful agenda and put it out in advance with pre-digested materials so that the doctors know what you're going to talk about. They can be thinking about it so that they can take meaningful action in the room. I hate meetings where it's all informational. I think most people do. You spend the whole meeting listening to someone tell you something. A well-crafted meeting has appropriately condensed material sent out in advance so that that part is taken care of. When you get in the room, it should be to debate the pros and cons of the various directions that you might go. And you have to run those meetings crisply and effectively and stop people from running on who like to hog the mic and bring out the comments of those who seem to be sitting back a little bit more, and then drive to a conclusion. I've heard so many doctors frustrated that at the end of a meeting, there was no conclusion. Well, that doesn't give them much incentive for showing up for the next meeting. I find that real governance power, which I've just alluded to, is really very critical and useful for developing physician leadership. But the other way in which physician leaders can engage doctors is through good data. Most doctors want their patients to do better. I would say essentially all doctors went into medicine because they really want to see their patients do better. And if they actually believe the reports and the bugs have been worked out and the attribution model has been clarified and the things that might invalidate a quality metric are tossed out and risk adjusted, when you do all that work to make sure the data is correct, doctors are very responsive to the data because they're competitive by nature. And doctors don't want to be the number 18 on a list of 20, and they'd like to see their patients do better. And they will naturally try to get their performance up if they actually believe the information. And one that's a really big issue is making sure that the end size on your metric or your Press Ganey result is adequately large, because performance is going to appear to bounce all over the place on a chart if you're only getting 2 or 3 responses a month. So I always say hold all the information till you have at least 30 responses, so it'll be statistically valid. Physician leaders have to persuade, so they have to do more than just get physicians to come to meetings. They have to practice and master skills of persuasion and change management. They often need to work with the finance people to come up with ways to pay physicians that aligns their incentives with the incentives of the organization to do well in a value-based contract. One of the things that I also think is very useful for persuading doctors is if they complain and say, well, this is always all dictated to us, and they're mad at the government or the Blue Cross or whoever it might be, I say to them, and I encourage physician leaders to say to them, well, if you want to have some control over your fate, join this committee where we're going to give you some real power to come up with the quality metrics, set the bar for performance, etc. And I remind doctors that what they really want to do is help their patients get better. But we also don't want to waste their time or decrease their ability to make a good living, and those have to be balanced. And one of the best ways that I like to help leaders persuade others is if you can just find one convert or one early adopter who buys into these quality metrics, or they've had a great experience improving their Press Ganey scores. I use them as a role model, and I take them around to other physicians and have them rub shoulders, because someone within the ranks who's viewed as a respectable member of the medical community probably has more influence converting their peers than an outsider can provide. Physician leaders really need to learn how to provide feedback effectively, not in a preaching way, not a condescending way. And I always remind physician leaders, when a report is new and you're just creating it for the first time, it's likely to have a number of flaws in it. So I teach physician leaders to go out tentatively with that report and say, hey, the first report's off the press. Can you validate this with me? And when I was a young medical director, I would sometimes go out with those reports as though they were the gospel truth. The doctor would be mad, grab the report out of my hand, and he'd say, well, no, this isn't correct because this person died 2 years ago, and this one moved to California, and this one is no longer my patient. He went to Dr. Smith down the road. And that's an attribution issue. Or they may look and say, well, the end size was only 2. And those are valid pieces of feedback, so you have to listen. But once, as we said, you clean up the reports, and the doctors have some faith in them, and they perceive that the leader respects their point of view, it's amazing how they come along. The other thing about population health management is it's based on whole populations. And so there's power in numbers, and it's hard and inappropriate, actually, in many cases, to use the data to micromanage physicians. It's better to say, this group is doing better than that group. Let's see if we can find out why. And doctors will more affiliatively want to learn from their colleagues, which is building a culture of quality improvement. It's great if you could create a forum as a physician leader that brings various physicians together who may have different performance on any particular measure and talk about their own best practices, how they got that higher level of performance. And I guess I've already alluded to this slide. You have to do predictive modeling and data analytics to figure out where the population needs to go. So let's say you've got 10,000 patients and their average hemoglobin A1C is 7.3 and you want to get that down. Well, you're going to talk in general about care protocols, but we all know that individual patients fall out of the standard. And doctors, by training and usually by philosophy, are very focused on meeting the needs of the individual patient before them. And it's quite an art and a learned skill to some extent for the physician leader to talk about the general best practice evidence-based protocol as what we ought to do in most cases for patients, and totally give doctors respect that there are good reasons to deviate from that protocol depending on the needs of a particular patient. I think sometimes inexperienced physician leaders get into internal conflict with a doctor about how to manage a particular patient. It's much better to talk about general rules that will move in aggregate those 10,000 patients in the right direction. And it's a team process. Not all the work needs to fall on the doctor. It's not appropriate for all the work to fall on a doctor. It's great to have care managers, care navigators, have your MA follow up on certain gaps in care, have the clinical pharmacist handle certain things for the sake of the entire population. So that's kind of a new and emerging skill. So if you develop a program to help your physician leaders, it has a number of benefits. I, through personal experience, have seen programs like this improve the patient experience, like specifically the Press Ganey results, if that's what you use to measure your patient engagement and patient satisfaction. I also am a big believer that if you invest in your doctors and respectfully listen to what they have to say and make course corrections with that feedback, that it increases their satisfaction and decreases physician turnover, which is very expensive. When you lose a physician to a community, you may lose hundreds, if not thousands, of patients to your competitor. You might spend hundreds of thousands of dollars recruiting and getting another doctor up to speed again. It can really take a toll on your patient satisfaction. So to stabilize your physician data, your physician base is very important. And of course, I've seen strong physician leadership bring to organizations much better financial results in their value-based contracts. And of course, what I love about it is improving health outcomes and lowering the overall cost of care. Here's an example of a typical physician leadership program. You can do one large scale or small scale at your individual institution, but it needs to be a longitudinal program. It can't just be a one-day seminar, we're going to get everybody tuned up and we're done with it. It has to be ongoing support. And we recommend that you start out with some assessments of the physician's skills, including assessments of their EQ, so that you can see what needs to be shored up, what needs to be remediated and emphasized. You can also learn specific technical skills that they may need. And of course, as I said before, every physician in leadership has a slightly different directive or job description. So you would want to tailor the technical skills and the softer people skills specifically to the needs of that role and the needs of that position. And then after going through the sessions, perhaps creating a forum for ongoing support, some people really benefit from individual executive coaching and some kind of mentorship program, either internal to the organization or an external coach. And this is just an example of a leadership program with some core sessions that I think everybody could benefit across the top of this slide. And then you could customize particular service offerings to the needs of that physician or the needs of that institution and role with some of those things that we've listed across the bottom. So in summary, more and more physicians are being called to leadership, and those physicians need help to be effective in their jobs. You want to select somebody who's got the natural characteristics of a leader, but sometimes you don't have a lot of choices and you have to work with whatever you've got. And even a strong leader can always be improved with some specific instruction, some coaching and mentoring, and to succeed in these value-based contracts. Systems need to invest in physician leadership to bring the rest of the physicians along, or else they will fail in the contracts, or they won't do nearly as good, nearly as well as they would do otherwise. So that's my overview, and I'm sure you have lots of specific questions that pertain to your physician leadership needs at your particular organization. And I just hope that through my 30-some years of experience of doing this, I might be able to have an insight that would be useful to you. So as Lisa said before, you can submit a question on your interactive interface there. And Lisa, do we have any questions that have been submitted?
Yeah, I'll just pause a second for people to submit questions if they have them. Using the toolbar at the bottom of your screen, you can use the Q&A function. Let me just take a second. So Dr. Faber, can you answer a question about how can you go about finding and recruiting physician leaders? What's the best way to go about doing that?
Well, in some institutions, people will say, I don't have a doctor who wants to lead. All my doctors just want to practice clinical medicine. And it differs from one organization to another. I guess it matters how big is the organization and what do you need the physician leader to do. But I look for informal leaders, people who in meetings come up with positive suggestions. I sometimes even twist it the other way. I listen for doctors who gripe and complain, and I approach them to see whether or not they're willing to do more than complain, and are they willing to roll up their sleeves so that they've got some stake in their own future. Sometimes you can convert those people. I also look for doctors that have shown any signs of desires to lead. For instance, some doctors will go off and get a Master's of Public Health or an MBA. That's kind of a telltale sign that they're interested in more than just practicing clinical medicine. I ask physician peers, who around here do you respect their opinion? I think some of the best physician leaders are ones where a doctor might say to me, well, I don't always agree with Jim, but I respect him. Or I don't always agree with Sarah, but I respect her. Because those are the people with informal leadership. And then, of course, you've got to work with these potential people that could be your leaders to get them over their concerns. Like, well, I lose money if I run a meeting, so pay doctors for their time to run the meeting. The data is all flawed. Great. Roll up your sleeves with us so we can clean up the data. Try to overcome the concerns of the best people that you can find within your own organization. And then sometimes, when you can find no one within your own organization, you look outside. There are a number of people these days who in fact are getting degrees in medical management, or they're doctors with MBAs, and they're looking for an opportunity, and they might even be willing to move to your community for such a job opportunity. So those are some of the ways I kind of look about for a physician leader.
And is there a specialty that makes better leaders than others? Which type of physicians do you think are better prepared for that type of leadership role?
That's a great question. You know, there are physician leaders across the country from every specialty. And I think it's the attributes of the particular physician that matters more than their specialty. Toby Cosgrove is the head of the Cleveland Clinic, or he has been, and he's a cardiovascular surgeon. He's done a remarkable job. Many of these jobs end up being filled by a primary care doctor, because primary care doctors by training are into preventive medicine or community medicine, and many of the quality metrics and programs that you have to create to do well in a value-based contract are primary care focused. But if you've got a specialist, an orthopedist or a cardiologist or whatever, who grasps the overall goal and they're not hostile toward the benefits of preventative care and primary care, they could make an excellent leader. And I've seen that as well.
Great. And another question is, are there any particular challenges for women in healthcare leadership roles that you've experienced?
Yes, I'm working right now with a relatively new female physician leader, and she says she thinks there's a gender bias and that she's not always taken seriously by her male colleagues. And of course, talk about grit and resilience. Fortunately, she's got high EQ and she can step out of herself and look at that as a social phenomenon, and she still keeps plugging away. But she can help herself by creating alliances, maybe with other female providers in her organization. But what I find is with any physician leader, no matter what might be a challenge for them, as it might be a challenge in some settings to be a female leader, once you get a critical mass of people that respect you, that grasp the concepts, because you have to educate them, it begins to snowball. I mean, I've seen this really in many, many situations where it takes a while to get the momentum going, but it will build. And so I would say that to encourage a female leader who may be encountering some resistance again.
Great. And another question is, not all healthcare executives have developed competencies in engaging physician leaders. Does Lumina have coursework for executives on how to effectively engage physician leaders and work within a new model that includes physician leadership?
Absolutely. We would be happy to work with any executive to help them learn how to better work with their physician leaders. And the reverse is true. A part of our curriculum for a physician leader is to learn how to manage up, how to manage board expectations and the expectation of a CEO that may be more financially driven in some cases than quality driven. So it's all a part, both of those topics are part of a thorough curriculum for leadership.
And what are some ways to work with physician leaders to get them to be more inclusive of team members' feedback and ideas?
I think the best way to do that is how you set up your governance structures. Um, Rather than saying to the chief medical officer, this is all up to you, the organization can place around them by the operating agreement or the bylaws of the organization that you need to have a CIN steering committee or an ACO steering committee or a quality committee composed of doctors, and it's a legal document, and it requires them to work with a group of their peers. Now, if that leader hogs the ball all the time and wants to just circumvent that, you're going to have to deal with that. And it helps a lot if there's any potential replacement for that leader so that they feel, oh, I need to actually do this, or else maybe they will call on someone else to do this. But I guess the overall answer to the question is it's how you set up structures, and non-physician administrators can help set up the structures to make sure that physician leadership is a more collaborative process.
Great. And another question is, do you endorse dyad leadership models?
Yes, I personally, I mean, it's not the only model, but I've worked in dyad leadership models for 30 years plus, and I find them extremely effective. one of the things a physician leader does by nature is act as a translator. They convert business principles into terms that a clinician gets, and they take clinical concerns and translate them into what the business leaders um, can understand and appreciate. And having a dyad partner that you can head up that conversation, that interface between business and clinical concerns is extremely useful. A doctor might get a finance course in their Physician Leadership Institute or in their MBA school, but it doesn't make them a pro like somebody who's been a CFO for 30 years. But it may give them enough of an understanding so they can have that dialogue and show their own credibility. And it's not just showing your credibility, it's being actually useful. I know a story of a doctor that just had a finance course in MBA school and knew just enough to look at a financial report and say, this is fishy, and ultimately found out that the CFO was embezzling. So a little bit of knowledge is useful, but having a dyad partner who has a deeper understanding, and they're your trusted partner that you communicate with on a regular basis, I think can be particularly effective, so that the physician's time is really dedicated to influencing peers around clinical issues, and not so much with making sure the budget's set up correctly or the books balance out right, or get into too many of the weeds with data analytics. They need to understand it in principle, but it's really good to have somebody else who can really spend their time on the details of the business.
Great. And one last question. What can a physician leader do to engage colleagues in improving quality metrics and value-based contracts?
I am a big fan of quality committees, be it an ACO or a CIN quality committee, where you get that grouping of physicians I talked about earlier on, usually 8 to 12, sometimes as big as 15, representing a difference of points of view, and conduct great meetings where, by charter, the committee has real power to change the future. Doctors often complain about quality metrics. They'll say, well, this one's meaningless. Why does Blue Cross or Cigna or PCMH or Medicare require that we do this? What I find is if you get doctors around the room to talk about the quality metrics that are handed down to us, first, they'll understand that quality measurement isn't quite as easy as they thought, and a lot of thought has actually gone into some of those metrics. But in many other cases, they have real power to say, well, we could potentially use these 40, but we're going to pick this subset of only 20 of those metrics because we find them more meaningful. And I think that's great, because if you don't have the physicians engaged in actually doing well in the quality metric, you're not going to do well. One of the bases for picking a quality metric is one where the doctors really feel like they can change it and that it should be changed. In other words, they're concerned, for instance, their mammography rate or their diabetic control or whatever. And these committees can be set up to set the bar. Not only we're going to use such and such quality committee, but last year we hit 45% of our patients that hit the metric. We want to raise the bar to 50 this year. But what's great is instead of raising it from 45 to 70, they say, nope, I think all we can really change it this next year is by 5 points. To give doctors that kind of real power to set the course of their own future, I find extremely useful. And I've seen many doctors who are very compelled by that. They have a satisfaction of helping control their future in a way that they heretofore had not had.
Great. Well, thank you so much for sharing this information. And thanks to everyone who submitted questions. We really appreciate it. Hope you got some valuable feedback from this webinar. And then if you can switch to the next slide, Dr. Faber. This is our contact information for Dr. Faber. And then also you can check out our website. You can follow us on Twitter, follow our company page on LinkedIn. And then we also have a YouTube channel where we post videos. if you're interested in following any of that content. Thanks again for joining us today, and we appreciate you attending, and we know your time is valuable, and we appreciate you spending it with us. Have a good afternoon.